Good evening, everyone. I thank Dr. Balabhaskar sir and all the coordinators of VAAA Ballari for giving me this opportunity. Today's topic for discussion is anesthesia for obstructive jaundice, and I will be dealing with the pathophysiology of obstructive jaundice. So, warm greetings from Dr. B.R. Ambedkar Medical College, Bangalore. And today we are going to deal with the structural anatomy of liver, the blood supply to the liver, how is it important to us, the metabolic functions of liver, and then we will move ahead with the pathophysiological changes in obstructive jaundice. So coming to the liver anatomy, liver is the largest internal organ weighing around 1.4 to 1.6 kgs. It takes 25% of the cardiac output and the total blood flow is 1.5 liters per minute. It has a dual blood supply from hepatic artery and portal vein, and the venous drainage is by the hepatic veins into the inferior vena cava. The nerve supply is from the postganglionic nerve endings T5 to L2. And you can see the choanal segments. This is all for important for the liver transplantation and liver segment and all those things. We are not dealing with that now. So moving ahead, the anatomical functional unit is the hepatic lobule. It is hexagonal in cross section. The blood enters the lobules through the branches of the portal vein and hepatic artery and through small channels called the sinusoids, which is lined with hepatocytes. So in between the lobules, there is portal triad, which contains the hepatic artery, portal vein, and the bile duct. But from the metabolic point of view, the functional unit is the hepatic acinus. So each hepatic acinus is divided into zones that correspond to their distance from the arterial blood supply. So the hepatocytes closest to the arterioles are best oxygenated. That is like zone 1, which is the periportal zone. Here the hepatocytes receive oxygen and nutrient-rich blood, but it is affected in the ischemia reperfusion injury. All the oxidative liver functions like phase 1 reactions take place in zone 1, and it has cholesterol synthesis also happening there. So in zone 2, it is little further away from zone 1, but it has better oxygenation compared to zone 3. So it's called the mid zone. Now coming to zone 3, which is centrilobular, which is furthest from the arteriole. So they are very prone to ischemia or hypoxia. So that is why, because it is very far away. So all glycolysis, lipogenesis, and cytochrome P450 based drug detoxification, everything happens in zone 3. They are sensitive to N-acetyl P-benzoquinine imine. So in paracetamol overdose, so centrilobular necrosis happens in zone 3. Same with the halothane hepatitis, centrilobular necrosis happens. And hepatocytes regenerate by mitosis up to 70% of original volume. This is important when it comes to living donor donation. So moving ahead, we'll talk about the hepatic blood supply. It is dual vascular supply by hepatic artery and the portal vein. Hepatic artery is a high resistance, high pressure system where 30% of the hepatic blood flow is supplied by the hepatic artery and 70% of the blood flow is by the portal vein, even though it is both giving 50% hepatic oxygen supply. So whenever there is a decrease in the blood flow, there is proportionate. When there is reduction in the map, there is decrease in the blood flow, which is proportionate. So you can see that there are intrinsic and extrinsic factors that affect the hepatic blood flow regulation. Among that, hepatic arterial buffer response is of importance because it is a pressure flow relation between the portal vein and the hepatic artery. When the portal flow decreases, there is more of adenosine accumulation in the hepatic arterial blood and bed, and so hepatic arterial vasodilatation will happen, and the hepatic arterial compensation will increase the blood flow by 50%. So among our inhalational agents, halothane affects the hepatic arterial buffer response. So what are the other factors that affect the hepatic blood flow? So hepatic blood flow is decreased in PEEP, or intermittent positive pressure ventilation. When there is hypocapnia, hypoxia, in diseases like cirrhosis, when we give beta blockers, halothane will decrease hepatic blood flow. All our anesthetic agents will decrease the hepatic blood flow. So what causes increase in hepatic blood flow is supine posture, acute hepatitis, hypercapnia. All this will increase the hepatic blood flow. Now we will move ahead with the functions of liver. Liver is an amazing organ which has different functions, starting from metabolism of carbohydrates, proteins, and fats, detoxification of all the drugs and toxins. It's a storage organ for glycogen, vitamins, iron, and copper. It's a reservoir for blood. It excretes bile and urea. It has immunological functions. It helps in the filtration of bacteria, degradation of endotoxins, and lactate metabolism. So here we are going to see what are the metabolic functions of liver. Coming to the protein metabolism, liver synthesizes very important proteins such as albumin, which is responsible for maintaining the colloid osmotic pressure. Around 12 to 15 grams per day of albumin is synthesized. Other drugs like globulins, glycoproteins, transport functions like ferritin, ceruloplasmin, others like antithrombin 3, alpha glycoprotein, acute phase proteins like C-reactive protein, all these are synthesized by liver. Almost all clotting factors except 3, 4, and 8, all clotting factors are synthesized by our liver. Amino acid degradation and ammonia is the end product, which is eliminated from the body by converting it into urea by the ornithine cycle. That also happens in liver. So coming to carbohydrate metabolism, our liver helps in the glucose homeostasis. So it maintains the glucose homeostasis during fasting by gluconeogenesis and formation of ketone bodies. Basically, it gives us a euglycemic level. Now coming to lipid metabolism, liver helps in fatty acid synthesis. So beta oxidation of free fatty acids, we get acetyl coenzyme A, which is part of the Krebs cycle. Any surplus fat, it's converted to ketone bodies. Now coming to the drug metabolism. So smooth endoplasmic reticulum of hepatocytes is the principal site for the metabolism of liver, drug metabolism in liver. So the drug metabolism is divided into phase 1, 2, and 3. So in phase 1 metabolism, there the enzymes, cytochrome P450 enzymes, they undergo various reactions like oxidation, reduction, hydrolysis, and all these drugs polarity will be increased, so they can get sufficiently water soluble, and if they are sufficiently water soluble, they get excreted at this point, like barbiturates, benzodiazepines, pethidine, all these undergo phase 1 reactions. Phase 2 reactions are conjugation reactions that include attachment of ionized groups to the drugs, and then it will increase the water solubility, allowing it to get excreted in the bile and urine. In phase 3, there is elimination using the ATP binding cassette transport proteins. So any dysfunction of the ABC protein, they will hinder the bile flow. It will predispose to drug accumulation and cholestatic liver injury. Now coming to the extraction ratio or first pass effect. So what is extraction ratio? It is the proportion of the drug that is extracted in a single passage through the liver. Basically, it tells us the efficiency of the liver in metabolizing the drug. So the extraction ratio is the intrinsic clearance divided by the hepatic blood flow. So there are few drugs with high extraction ratio like propofol, fentanyl, morphine, meperidine, verapamil, labetalol, all those beta blockers. And low extraction ratio are thiopentone, diazepam, digitoxin, and all. So the drugs with high hepatic extraction ratio, it is unaffected by the protein binding. So it is only affected by the changes in the hepatic blood flow. Now coming to the bilirubin metabolism. So 80% of the bilirubin is coming from the breakdown of RBCs. So 6.5 grams of hemoglobin gets broken down per day, along with other sources like myoglobin and all. This hemoglobin gets converted to heme and globin, the macrophages in the reticuloendothelial system, and almost 230 milligram per day of bilirubin is produced. So in the circulation, this bilirubin is bound to our albumin and it is unconjugated bilirubin. Once it goes into the liver, their conjugation happens by glucuronyl transferase. Our bilirubin becomes conjugated bilirubin. Then it goes in, got excreted as bile and passes through the intestine. It gets converted to urobilinogen, stercobilinogen, and excreted as feces. 85% gets excreted as feces. Among this, 15% goes into enterohepatic circulation. So the urobilinogen get reabsorbed in the colon and it goes back into the liver by the portal system. So that's how bile salts are conserved. And 1% goes into the hepatic circulation and it is excreted via the kidneys. So the bile is almost 500 to 1 liter of bile is secreted daily. It will get collected from the right hepatic duct, left hepatic duct, it goes into the common hepatic duct and goes into the gallbladder, gets stored there. There it will get concentrated by 1/5. So it contains, the bile contains water, bile salts, bile pigments, cholesterol, and inorganic salts. So all the bile acids are produced in the liver from the cholesterol. In the gut, this gets acted upon by the bacteria into secondary bile salts, which gets conjugated to form the bile. Secondary bile acids get conjugated to form the bile salts. Now let's talk about the pathology. What are the different types of jaundice? There is 3 types: prehepatic, hepatic, and post-hepatic. Usually prehepatic is because it is in the circulation, mostly because of the hemolysis. This is medically managed. And next comes hepatic. It is caused by viral hepatitis, drugs, cirrhosis, and tumors. It is both conjugated and unconjugated. That also can be mostly managed by medical management. What we are concerned is the post-hepatic cause of jaundice. We'll deal with that. So what are the causes of obstructive jaundice? It can be intramural causes like congenital atresia, sclerosing cholangitis, benign structures, tumors of the bile duct. Intraluminal causes like the gallstones, any parasites, foreign bodies, and extraluminal causes like malignancies of the liver, CA pancreas, like the head of pancreas, periampullary carcinoma. All that can be the extraluminal causes of obstructive jaundice. Now, let me just briefly talk about the test for liver functioning. So based on the detoxification and excretory function of the liver, how we will understand is by checking the serum bilirubin, urine bilirubin, and blood ammonia. Usually in normal kidneys, a normal liver function, urine bilirubin should be absent. So what are the other functions? Like biosynthetic function can be checked by measuring the serum albumin, serum globulin, and coagulation factors. Now, what are the enzymes indicating the liver injury? When there is damage to hepatocytes, the aminotransferases will get elevated, like aspartate aminotransferase and alanine aminotransferase. But when there is cholestasis, the specific one is 5-nucleotidase. Specific and sensitive one is 5-nucleotidase, but alkaline phosphatase will be markedly elevated and gamma glutamine transferase will also be elevated. So you can see that when there is obstructive jaundice, alkaline phosphatase is markedly increased compared to our ALT and AST. So that helps us identifying whether it is a hepatocellular jaundice or an obstructive jaundice. Now let's come to our main discussion. What are the pathophysiological changes associated with obstructive jaundice? So you can see that there is yellowish discoloration of the sclera, skin, and the mucous membrane. The most the initial symptom will be pruritus, which is because of the deposition of the bile salts. So you can see that there is unconjugated bilirubin coming, getting conjugated, but it is because of the obstruction, there is increased conjugated bilirubin causing elevated ALP levels. So the bile salts and bile pigments will be present, but urobilinogen will be absent. So and stercobilinogen, so they will have clay colored stools and pruritus will be there. Now let's come to the major manifestations like cardiovascular changes. What are the cardiovascular changes because of obstructive jaundice? In cholecystitis, there can be increased cardiac output due to the decreased peripheral vascular resistance and hyperdynamic circulation. Due to circulating bile salts, patient can have bradycardia because the bile salts will have a direct effect on the SA nodes. There can be impaired cardiac contractility, impaired response to the beta agonist drugs. So what happens is your hypotensive patient is prone for circulatory collapse. Any bleeding, they can have an exaggerated hypotensive response. So fluid management is the key here. You have to perioperatively load the patient, otherwise patient can lead to circulatory collapse. Now coming to the renal dysfunction, more than 20 milligram percentage of bilirubin, if it is there, that is directly toxic to the renal tubules and ends up in acute tubular necrosis. So any renal vasoconstriction due to the reduced effective plasma volume leading to renal hypoperfusion and decrease blood from the spasmodic circulation to the central circulation, all this leads to pre-renal acute renal failure. If there is prolonged cholestasis, that will lead to tubular ischemia and patient will end up in acute renal failure. So hepatorenal syndrome is not part of cholestasis, but it's just for completion's sake, it's the complication of advanced cirrhosis where there is renal failure, intense renal vasoconstriction with extreme arterial dilatation in splanchnic blood. There are two types, type 1 and type 2. Among this, type 1 is having very poor outcome. So now let's go back to the coagulation problems that we will face in obstructive jaundice. See, we know that bile salts will help in the absorption of fats. So that is affected. So because of that, the fat soluble vitamins like A, D, E, K absorption will be affected. So vitamin K dependent floating factors like 2, 7, 9 and 10, there will be reduced synthesis. So that will lead to elevated prothrombin INR and APTT. And there is prolonged obstruction. There can be endotoxins that can lead to thrombocytopenia and platelet dysfunction leading to coagulation problems. So how can you prevent that? You can prophylactically give vitamin K or fresh frozen plasma when it is emergency. Now coming to the gastrointestinal effects. When there is prolonged obstructive jaundice, patient will end up having malnutrition. Because of the malabsorption of fats and steatoria, patient can have vitamin A, D, E, K deficiency, which are the fat-soluble vitamins. Patient can end up having stress ulcers, peptic ulcers. When there is intestinal mucosal barrier dysfunction will happen, bacterial translocation will happen and gram-negative bacteria leading to sepsis, biliary sepsis will happen. So that also has to be taken care by giving empirical antibiotics. Now coming to the immune function and detoxification, there is defects in the cellular immunity. Usually what happens in the endotoxins which is produced, it will be transferred from the gut to the portal circulation. But when there is a reduction in bile acids in the gut, there is increased absorption of the endotoxins into the systemic circulation, leading to systemic hypotension, renal hypoperfusion and failure, and coagulation disorders. So when there is increased bile acids in the blood, there is Kupffer cell functioning will also be impaired, leading to defects in your immunity. Now comes to the drug elimination and pharmacokinetics. Liver plays a major role in our drug metabolism. Because of the affected synthetic functions and metabolic functions, there is altered drug metabolism and elimination. So there is a reduced absorption of fat-soluble drugs after an oral administration. Because of the compartmental changes and altered protein binding, like synthetic function, albumin will be reduced. So altered protein binding, the drugs bound to albumin, or altered volume of distribution, clearance and redistribution. Because of the reduced hepatic extraction, there can be high peak plasma concentration of the drugs which is bound by albumin. So the drugs with high hepatic extraction ratio, you should take care that there should be dose reduction and not the reduction in frequency. But the drugs with a low hepatic extraction ratio, there need not be any dose reduction, but the dosing intervals need to be increased. Like diazepam, digitoxin, etc. So what is the take-home message? Our liver has a multitude of functions. So patients with obstructive jaundice can develop nutritional deficits, coagulation disorders, hypotension, acute renal failure, biliary sepsis. So what we have to do is we have to give nutritional support, vitamin K supplementation, thorough cardiovascular assessment in view of all the bradycardia and arrhythmias, perioperative fluid management and hemodynamic optimization helps us to manage our patient with obstructive jaundice better. Thank you. If there are questions are there, I'll take it now. Thank you once again.